All right. Hey ho, let's go. This is Resistance Radio, where natural selection selects resistance, and we're here to make sure public health doesn't get naturally selected out. So today's story has two threads that really should be talked about together. On one side, an Ebola outbreak in Central Africa that's getting bigger and more dangerous by the day. On the other side, the slow weakening of the very systems that we rely on to spot, stop, and manage outbreaks, especially here in the US. So let's start with the Democratic Republic of the Congo. The current Ebola outbreak there is caused by a strain called Bungdi Bungju, one of the lesser known cousins of the Ebola virus that terrified the world in West Africa about a decade ago. That strain is the Zaire strain. Now, since the outbreak was officially declared on May 15th, field groups like Doctors Without Borders have reported more than 500 suspected cases and about 130 suspected deaths. That's roughly equivalent of everyone in a large apartment building getting sick and an entire crowded movie theater's worth of people dying in just a couple of weeks. Now, over the weekend, the head of the WHO raised the risk level within the Congo from high to very high as suspected deaths pushed past 170 and cases climbed upwards of 750. Now, the WHO says the regional risk in Africa is very high, but the global risk is still low. This is not a worldwide emergency in the technical pandemic sense. Think of it like a wildfire that's raging in one region. If the wind doesn't shift and the fire breaks hold, it won't jump continents, but it's already devastating when it does burn. Now, here's the uncomfortable part. Ebola is exactly the kind of disease that tests whether the world's public health system is awake and functional. So it's deadly. It spreads through close contact rather than the air. And we have tools, supportive care, vaccines, and hard-won experience to control when these tools are actually deployed. The differences between an outbreak that burns out and one that spirals is how fast we detect cases, protect healthcare workers, and support local communities and share information honestly. So, while that's playing out in Central Africa, the U.S. is quietly making itself more vulnerable the next time it sits in the hot seat. Over the past year, senior public health leaders have described the CDC as in quote unquote critical condition, in their words, not mine, after leadership firings, political interference, and waves of internal resignations. At the same time, infectious disease experts have been warning that big cuts to CDC and NIH budgets plus the U.S. walking away from the WHO membership are exactly how you hobble your response to the next big outbreak. It's a bit like deciding to save money by ripping out the smoke detectors out of your house while pointing to your neighbor's house that's on fire and saying, well, it's over there. Sure. Right now, the big flames are in another neighborhood, in this case, another continent. But the whole point of having strong public health agencies and global partnerships is that they work before the flames reach your door. Now, the story doesn't stop at labs and conference rooms. Health policy briefings this spring have laid out a Trump administration budget that would cut funding for key health and research agencies and eliminate some programs entirely, including work focused on minority health and vulnerable populations. At the same time, stricter immigration screening for foreign physicians make it harder to bring in clinicians to fill gaps, even as the U.S. hospital keeps even as U.S. hospitals keep leaning on international medical graduates to staff emergency departments, ICUs, and rural facilities. Imagine shrinking your bench in the middle of a long season and then acting surprised when you run out of players in overtime. When you put all these threads together, the Ebola outbreak abroad, the weakening of CDC and NIH, the U.S. leaving the WHO, the budget cuts, the slower pipeline of physicians, you get a picture that should feel familiar after the last few years. We've been saying that we've learned the lessons of COVID. Meanwhile, we're dismantling some of the very systems that are supposed to prevent the next big one. So what does that mean for you? If you're not a health worker or a policy nerd, here are a few concrete things. First, the Ebola outbreak in the Congo is a real humanitarian crisis, even if it never becomes a global one. And it deserves attention and support, not just in country, but through international aid and vaccine logistics. Second, when you hear about cuts to public health budgets, CDC, NIH, or decisions to distance the US from WHO, that's not abstract bureaucracy drama. That's someone quietly removing the fire exits from the building that you live in. Third, elections and policy choices absolutely change how prepared your community is when the next scary acronym hits the news. Ebola, the new flu strain, disease X, whatever the name. We either invest in an immune system for society or we live in a chronic long COVID for our institutions. Now, the good news is that we still have choices. We can fund the people who run into outbreaks instead of run away from them. We can stay in the room with the WHO and with other countries rather than pretending germs respect borders more than politics do. So, this is Resistance Radio, where natural selection selects resistance. And we select not to defund the referees right before the next big game. So stay informed, stay kind, and remember, germs don't vote, but they're very good at exploiting our political decisions. Thanks for tuning in.